have an PhD in experimental psychology. I got that in 2004 from the University of Vermont. My real focus within that field of experimental psychology is the study of psychoactive drugs. You could call it behavioral pharmacology. I've really studied all the major drug classes, everything from stimulants like methamphetamine and cocaine to alcohol, caffeine, nicotine, opioids, cannabis, but I've done a whole lot of work with psychedelics, starting 21 years ago. And for the last 10 years or so, I've had my hands in a number of things, studying some other drugs such as, tobacco and the role of nicotine and tobacco dependence. But with psychedelics, I've really been focused on some therapeutic studies using psilocybin to treat cancer distress, using psilocybin to treat depression, using psilocybin to treat tobacco addiction, which is really the main thrust of my current work, although I have interests all across psychedelics, including the dark side. I've done quite a bit of focus on risks and safety factors in psychedelics, how to keep people safe.
How did you first get introduced to psychedelics?
I did a paper when I was in college, an undergraduate paper, and discovered this kind of older era of research from the 50s to the early mid 70s where LSD was largely being used for a number of disorders. You really sort of discovered that it wasn't that we found that psychedelics weren't effective as mental health treatments. It was really just this socio-political um, environment, their association with the counterculture and everything like that, and a whole lot of other factors that, during the 60s, there were the Manson murders at the end of the 60s. LSD was involved with that. A little bit further in the 70s, it was revealed that the CIA was using psychedelics clandestinely for in some very nefarious experiments. And all of that just provided a really bad taste in the mouth for society regarding psychedelics. So they kind of went from at the edge of mental health treatment, like really the frontier, to really just, you know, uh, the third rail, you know, just something that made people crazy. Not only would it make your kids weird and put flowers in their hair and protest the war, but it might actually make them homicidal maniacs like Charles Manson's followers. So, they were just stigmatized for really decades until this research slowly started creeping up. Um, and I was lucky to get involved with that research when I completed my PhD in 2004.
So, years now after having worked with psychedelics, do you believe in some of that hysteria that existed from the counterculture? Is there any validity to that?
It's important to remember that some of the stigma from the 60s wasn't based on nothing. There's a kernel of truth. Surely it was overblown, and the research itself shouldn't have been sacrificed. But there is a dark side. I mean, for one, a lot of people took LSD. The doses on the street were about 6 times higher than they are now. There were a lot of bad trips, and it's humbling to talk to some of those older psychiatrists and others and nurses that worked in the emergency rooms back in those days in the late 60s. Uh, there were definitely some young folks and others that, especially ones that had psychiatric vulnerability and or took it in really suboptimal, chaotic settings that were really hard. Now, also, there were lots of people that took LSD and other psychedelics that will today say 50 years later, it was one of the most important things they ever did. And they can tell you a narrative and how it changed the course of their life in a positive way. And both are true. So, we have to keep that in mind. And, there is still a dark side. One of the things I'm concerned about as we move forward, as there's continued access and expanded access, is that, it takes a great responsibility. For example, as therapists, I see a very strong likelihood that we're going to see an increasing number of therapists that kind of go down what I call the guru route, especially because experiences are often very profoundly spiritually meaning. It's very easy to kind of step into that spiritual guide role, um, really kind of move it away from the patient's experience and letting them be the chief meaning maker from that experience, and to kind of fill that role of spiritual leader, professing to be an expert on metaphysical levels where honestly it doesn't matter if you're a scientist or you have a PhD in clinical psychology. No one's an expert on this. Um, Everyone has a right to their own opinion, and they're just as valid as far as anything you can determine objectively. And you're also going to see a lot of therapists sleeping with their patients. I mean, that comes along with, you know, kind of a cult of personality. You can see people, I mean, the two big things like folks, fleecing their patients out of money and sleeping with a bunch of them. I mean, those are kind of the classic things. And we know that this happens in mainstream helping professions, social work, psychiatry, clinical psychology, where something around 10% of therapists will say during the course of their career that at some point they had a romantic relationship with a client. And so that's without powerful mind expanding drugs. So there is like reason for concern, especially even within the, not just in the, using these drugs in a party setting, but even in, intentional therapeutic use. So it's something that just requires training, visibility and transparency, which is one of the extra concerns when things are underground. You obviously have less transparency. Well, so when there are bad actors, can they be called out? Can there be a course correction? And you know, ultimately, I think it's best when there's the appropriate regulation. Somebody's doing something wrong. There's a regulatory body to come in and say, "Hey, yeah, you can't do this anymore," or you have to undergo some correction to you know um, improve the way you're doing things.
Based on your findings, how important are mystical experiences in successful psychedelic treatment?
It appears that mystical experiences are related to the likelihood of therapeutic outcomes. So, decreased depression and anxiety in cancer patients, um, decreased likelihood of being a smoker uh, many months after one's quit attempt. And, these aren't perfect correlations. It's sometimes been overstated that a mystical experience is necessary for the therapeutic effects. That's definitely overstating it. And there's plenty of folks that don't meet criteria for the so-called full-blown mystical experience, but that they're nonetheless helped very much. And there's also folks that have a full-blown mystical experience by all accounts. And, we don't see the therapeutic target, the reduction in depression, anxiety, or the reduction in substance use. And some studies haven't showed this relationship. For example, with MDMA, it looks like mystical experience is less related to therapeutic outcomes compared to the work that's been done with psilocybin. So it's an important thing to keep examining, but it's just scratching the surface. It does appear more broadly. There's other aspects of the subjective experience that seem important. So the sense of emotional breakthrough, this which is sort of like the sense of catharsis to what degree you're having a very emotional experience, and whether the experience seemed to relate to personal insight. So those are other aspects of the subjective experience along with mystical experience that seem to show some relationship to whether it's a therapeutically helpful session. But I do believe that subjective experience in general is going to be necessary for the long-term therapeutic outcomes, at least in the models that we're using right now, where you have 1, 2, or 3 sessions with these compounds, and we're seeing improvements, for example, 6 months or a year later. So I think it's great folks are exploring these so-called non-psychedelic analogs, perhaps inducing similar neuroplasticity. If there's a future therapeutic use there, I simply think that's gonna be a very different therapeutic model. I don't think you're gonna take one of those once and see improvements in depression or addiction, months later. That would be more of kind of a standard psychiatric model where one is taking the substance on a more chronic basis to address symptoms.
You published some of the earliest modern guidelines on psychedelic safety. Could you briefly explain the core principles of psychedelic therapy safety guidelines today and why they're important?
Yeah, in 2008, I published so-called safety guidelines for administering high-dose classic psychedelics like psilocybin or LSD. And some of the basics of the recommendations were, you know, you have to screen people. We have pretty good reason to believe that certain folks shouldn't be exposed to psychedelics. For example, people who are either dealing currently with psychotic disorders such as schizophrenia, or you can identify in structured psychiatric interviews that they have an identifiable predisposition for those types of disorders. Also, people at the more severe end of cardiovascular disease. Um, Not a concern for the large majority of people, but for those type of folks that, um, maybe their doctor says, "Yeah, you really shouldn't take the stairs at work," anything that can kinda push your blood pressure or pulse up could be dangerous, so take it really easy. I mean, those people are, generally speaking, the type of folks who might be in the category of, yeah, because psilocybin and these other compounds can have typically modest increases in your blood pressure and pulse, those are the types of people who could be at elevated risk. So you screen for that, and then the next uh, important aspect is preparation. You spend any number of hours, and that's varied across studies, and we don't know scientifically what the magic sort of minimum threshold is. My gut tells me something around at least 2 hours. A lot of the early studies range from 4 to 8 hours. In terms of the time spent between the so-called guides or the therapists, whoever is gonna be with them in that room when they're on the psychedelic, between them and the patient or the participant, the person taking the psychedelic, you don't wanna be around strangers. That can add to paranoia and anxiety. You want someone you developed a rapport with, who can verbally reassure you, if you have some strong anxiety, and can hold your hand. That could be very powerful in helping you through it. There should be the limits, I strongly believe, to the touch because of concerns about boundaries and, sexual violations, but I think it should be prepared and consented that, you can hold the person's hand. That can be really powerful in helping someone through it. Um, and then there's the session itself. Everything should be prepared. The person should know the environment, the session room that this is gonna take place in. There should be no surprises. The person should be kept safe in this whatever that container is, monitored continuously. So, for example, if the primary therapist needs to uh, go use the bathroom, there's someone, either a second person there or someone who can move into the space to take over for them, someone that the patient has also developed a rapport with. Um, and then there's the so-called follow-up or integration phase. So this is the day after, and depending on the study and the therapeutic model, it could be extended beyond that, the next week, several weeks beyond. But this typically involves, discussion with the patient to help them make meaning, if any, is to be found out of these experiences. And also that importantly, that provides an opportunity for um, assessment of safety. Is the person experiencing some um, atypical, but, you know, certainly possible persisting effects that could be troubling them? There are disorders out there such as HPPD, hallucinogen persisting perceptual disorder, people that had perceptual anomalies after the psychedelic experience. Fortunately, that hasn't really cropped up in the modern era of psychedelic research, probably because of this extensive screening. Maybe we're weeding out people that somehow have a predisposition for that. Serotonin syndrome is something that we see in the field, typically associated with recreational, or let's just say non-professionally guided or non-scientific exposure, people taking psychedelics on their own or with their friends. And typically that results from the other medications or drugs being on board that can augment the serotonergic responses. Serotonin is one of the neurotransmitters in your brain, and these various psychedelics can affect serotonin. Drugs like psilocybin can essentially fit into the same receptor that the serotonin in your brain would normally fit into. Um, MDMA is a little different. It releases a lot of your natural serotonin. Um, but there are situations where people are on other medications that also have effects on the serotonin system, and you can have too much of a serotonin response, and that can be very dangerous. So these are one of the parts of the screening and preparation is that you want to either exclude people on a certain number of drugs or, depending on the study, taper them off or make sure they don't take them the day of the session. And all of this depends on the drug and its half life. And it gets, there's a lot to evaluate there. But that's probably why we don't see things like serotonin syndrome and, the person achieving dangerous levels of other medications in these, um, clinical, trials. And then HPPD, hallucinogen persisting perceptual disorder, um, it's still very mysterious. It seems very clear that it goes on, that people have these effects. We haven't seen it in the research. Uh, we need to keep our eye on it. My My gut tells me that it's the type of thing that you may not see when you run a few thousand participants, but when you're running tens of thousands, hundreds, millions, when it's approved as a medication for therapeutic use, and this would also apply to, potential underground therapeutic use, you're going to see more cases of it. And so when it does come up, it's just going to be important to identify and hopefully figure out some prediction. Can we figure out what type of person is particularly prone to it or what conditions? Maybe they've been doing something recently, or that puts maybe there's a drug interaction that makes people especially vulnerable to it. And that's also one of the issues with anything that's underground. If we don't bring things above board so we can clearly see it, so a therapist conducting a session illegally is not going to want to catalog this into a national registry of adverse experiences, which is what we really need to do. We need to connect the dots, especially with those more rare adverse effects.
Can you talk to me a little bit about what you think of the underground therapist scene?
Yeah, the underground therapist scene is certainly a part of modern psychedelics, and because it's underground, I think you just get a wide spectrum, you know? I certainly have heard of and read about and and familiar with, therapists that are doing things that in many ways really mirror some of the best clinical trials in terms of, screening and preparation and ethically conducting these sessions. And then you hear horror stories where, I mean, just everything. People conducting sessions in dangerous locations where the person might get hurt, or, the pretty common one is sexual abuse during or after sessions. And I would say after sessions definitely counts. I mean, to enter into that relationship with someone, well, you're trusted in that, sort of hierarchy of having someone. The patient may be telling you as a therapist something that they wouldn't tell their closest loved ones because you were in that special place and that therapeutic relationship. And it's just not fair that someone can sort of take advantage of that vulnerability that person's put themselves into. And so that, certainly goes on. Um, I'm very concerned about the provision of really metaphysical advice. Certainly, I don't. don't encourage, sort of that you need to impose materialism and you need to do this work in a white room and that if someone has a religious or spiritual interpretation, say, no, 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 that was just your serotonin two-way receptors. Um, no, it's just that my strong feelings are that you need to let the client or the patient drive the bus. If they interpret their experience as um, Jesus coming into their heart, or an experience of their ancestors, or plant spirits visiting them, or a manifestation of the Buddha, great. I can't, say that I can neither confirm nor deny those levels of experience. But you don't. That's not your role. And so one of the things I'm concerned about is just that therapists playing a heavy hand, because there's a real risk. Psychedelic therapy can work really, really well. And one of the and when it works well, it works really well. And there's a huge risk there that you can really come out of it thinking as a therapist that I'm God's gift to therapy. Look at the healing I've done with these people. So it can be a lack of humility that no, I'm lucky enough to be using this very, very powerful technology. And this person has trusted me to play this role in, as part of this technology or this tradition. And it's not about me. I mean, certainly you need to be confident, you need to be caring. I don't want to say the therapist is not important, but you're in a service role. You're not a spiritual guide. Those are my views. So if during the session, if you believe you've had an experience where Jesus has visited your heart, or if you feel there's been a manifestation of the Buddha, or there are plant spirits that have come and visit you, if you've experienced your ancestors, if you feel something has gone on with your chakras, um, it's not the therapist's role to confirm or deny those experiences.
Have you ever heard of anyone losing their license from practicing in the underground?
I've heard rumors of people losing their license because they were practicing in the underground. I really don't have any definitive information on that. It's not something that I, closely follow. But it wouldn't surprise me at all that there's a reality there. And that's one of the risks, presumably, of conducting underground psychedelic therapy work. Thank you.
We've asked others about ideal training for psychedelic therapists. Based on your research, can you talk to me a little bit about what's essential in training these therapists?
I think the most important thing in training psychedelic therapists is, first of all, to be well trained in one of the relevant helping professions. And it's not restricted to psychology. So there's clinical psychology, there's psychiatry, there's social work. I think nursing can play a very strong role. And nurses are fit to serve in the role of psychedelic therapists. But I think, a solid foundation and in those core disciplines is the most important part. That's not going to cover everything, but the biggest concerns, for example, around boundary violations, you're going to find training in all of those disciplines. The way you might not, for example, if someone's exclusively trained in the underground for psychedelic therapy, it's like the boring old boundary violations and professional codes. Like that's probably less likely to be a focus. So I think a core foundation in those disciplines is important. But then, uh, certainly some type of internship is ideal where people can serve in a secondary guide or secondary therapist role in the room, where they're not the only one, they're learning from someone who's more experienced. Um, Beyond that, there's a lot of variability in these training programs that have crept up over the last 10 years. Some of them haven't seemed to be ideal. I think some of them have evolved. Um, it's I've seen people, tout themselves as these kind of great trainers of therapists, and they actually haven't conducted many psychedelic therapy sessions themselves. Um, so I think we have to pay attention to the humble voices and the folks that are well regarded amongst their colleagues. Um, and yeah, and to be open about how we that are we're going to learn things about how we can optimally train psychedelic facilitators, psychedelic therapists. So being willing to adapt as we learn uh, new information into training programs.
What do you feel is holding back the psychedelic movement from having more funding, more research, and being able to make progress faster in comparison to other treatments that seem to get by a lot quicker? Is it social stigma? Is it the pharmaceutical industry? Is it something else that I'm missing? What's holding back the movement?
I think the biggest challenge traditionally over the last 21 years that I've been in psychedelic research, biggest challenge has been funding. Um, that's changing, certainly now with certainly industry sponsors moving compounds through the FDA pathway. You don't always get the let's see, you get good science from that, but it's very narrowly focused on achieving FDA approval, so you don't get the most interesting science. It's good and necessary science to be clear, but you don't get the most necessary science to move the field forward in the bigger picture from that. There's an increase in funding by government agencies. I received the first NIH grant in the modern era to look at the therapeutic use of a classic psychedelic. This is psilocybin for tobacco smoking cessation. So there's an increase in NIH funding. We certainly need more. There's also an increase in funding by other government agencies within the U.S., such as the VA and the DoD. Um, so we need more of that, more philanthropy. I don't, I- at this point, I'm not sure that the stigma is holding us back. There's almost like the potential hype might be stronger than the stigma. I think there's a lot of excitement now, including by the government, um, which is a weird world to land in at this point. And it's also true that crazy enough that right now in 2025 U.S. politics, support for responsible psychedelic medicine might be the most bipartisan issue in U.S. politics. Particularly, there's a lot of conservative support for the very promising work for treating PTSD in veterans, so that's a big source of that interest on the conservative side.
Some scientists we've talked to have shared personal experiences with psychedelics. Have you personally experienced psychedelics in the research context or outside of one that you're comfortable talking about?
I haven't experienced psychedelics in the research context, so there have been some studies that have allowed pe people, scientists or others that are involved in the psychedelic area to actually participate in a study. I haven't done that. I still deflect the question on whether I've personally had an experience, but I'll tell you why. I think it points to an important domain. I think the question points to a really important concern. Does the person have an empathy? Do they understand the potential range of experiences, how intense this can be for people? Um, I've seen psychedelic therapists with and without personal psychedelic use, and I don't see a very tight correlation between whether they have had that experience and how good of a therapist they are. There are plenty of people that have taken lots of psychedelics that you go to nowhere near a patient for any number of reasons. And there are also just some very, very caring, empathetic folks who haven't had those experiences, who have listened to many people with psychedelic experiences. And we have to keep in mind that just because you've had any number of psychedelic experiences, you haven't had the experience that that person is having that day at that time. So, for example, in the work I did with cancer distress, I don't know what it's like to be a 70-year-old grandmother dealing with lung cancer, having a psychedelic experience. So, I think another mistake from the 60s, and Tim Leary, even though he was brilliant and made many great contributions and encouraged people to read his work, But, one of his downsides is that I think he could make this more about the experience of the scientist or the therapist than about the patient. Um, and we are still living in a world where, in most cases, psychedelic use is illegal. So I kind of still remind, younger folks that, hey, you might be cautious in what you choose or not to choose to share, um, because you don't want to engage in anything that's going to cause problems for you.
We've interviewed several people with varied views on psychedelic legalization, from broad legalization all the way to strictly therapeutic use for veterans. What is your stance on how psychedelics should become legal, accessible, and why?
I tend to think more about and like to use the language of regulation rather than legalization because even it's kind of a false dichotomy. Okay, we think alcohol's legal. Well, no, it's not for those in the US under 21. And no, it's not while you're driving. So sometimes that's an illegal substance. You might think, oh, psilocybin is an illegal substance. Well, it's scheduled, Schedule 1, but no, it's not in the context in an FDA and DEA approved clinical trial, such as I've conducted. And even something like caffeine, yeah, in the form of coffee or tea, there's pretty much no regulation. But even in soft drinks, the FDA regulates the caffeine content. And over-the-counter products like NoDoz or Vivarin, you can't just put any amount of caffeine in there. That's an over-the-counter medication. So there's typically more of a nuance there, and so I think about what is the drug and what's the appropriate form of regulation. There are many drugs that I don't want readily available, at the convenience store. Cocaine at the convenience store, bad idea. Should people who are addicted to cocaine be able to access in a safe use place and make sure that they're not using a supply with adulterants that could be very dangerous, for example, spiked with fentanyl. Um, yes, I think that would be a more appropriate form of regulation. So with psychedelics, um, there's a number of models. The biggest thing is I think we need to kind of look at the early evidence that different cities and states are playing with. It's a naturalistic experiment unfolding. I One of the older models that's been discussed, I don't think's been implemented yet, is it's sort of the driver's license model, that it's legal to access only once one has essentially conducted a driver's test. They, inserts, part of that would be didactic and filling out a test and maybe some of that would be use under supervision. Maybe some of that would be psychiatric screening. I think that's an interesting model. There's also I do remind people the Netherlands has had a model, not full legalization because it's technically illegal, but decriminalize tolerated access, at these so-called smart shops for decades now of either mushrooms or there was a nuance in the law where they switched to truffles years ago, which are essentially the roots of the mushrooms, but whatever, same thing. You eat enough, you're gonna have as much psilocybin, as you desire. But, and that's available without these, levels of, psychiatric screening or training, etcetera, and there have been harms, but one has to really look at the data and admit that, yeah, the harms have been relatively minimal. They're nowhere in the same league that the harms from alcohol and, other illicit drugs like, opioids and cocaine. Um, the most typical issue that has had monitoring it on a regular basis, but it's, the typical case is, young British males, like, taking a flight over the channel and getting there, um, they'd had a night of drinking and then decide, "Oh, let's do some mushrooms too," so it's in combination with alcohol. So, there is a pretty good track record of relatively safe use even amongst a pre-liberal policy, um, one that, has point of sale, distribution, and, one that presumably, even in that model, you still have control over the supply, and if something happened, there was somehow a tainted supply, there's an ability to track what happened and where that came from, and presumably prevent that from happening again.
Thank you.